We see what we're in for today. We're going to start with some introductions and opening remarks. We will speak about the Collaboration Prize and the inspiration for the Collaboration Prize, which was made possible thanks to the Henry family through the Henry Family Advised Fund. We'll speak about the process that went into motion since November to now, and we're really delighted that we have 6 Collaboration Prize finalists who are going to be joining us today for a TED-style quick pitch, followed by an interactive question and discussion panel. And then we'll wrap things up. We are going to invite our members, members only, to vote online. And the vote will be open for 1 week, and that will wrap up Friday of next week. So we will send out links after this webinar. If you have any questions, all of the pitches are going to be online on our website. Without further ado, if we can go to the next slide. And these slides will be made available online afterwards. So this just gives us a quick overview of the webinar. And actually, I will pause there for a moment. I just wanted to confirm with the team, are we live and recording now?
Yes, we are. Thank you, Mira.
Thank you, and sorry about that. Just want to make sure that we get this online for everyone. So without further ado, I want to introduce our Executive Director, Mr. Brendan Allen, and he's been spearheading this prize. Brendan's going to share some opening remarks, and following Brendan, we are really honored to have Mr. Orion Henry. Orion Henry is representative on our Board of Directors and is also part of the Henry Family Advised Fund, in addition to being someone who's worked in cloud computing and kind of a pioneer in there. So we're very delighted to have him joining us today as part of our question panel. So maybe we can go to the next slide and I'll hand it over to Brendan.
Wonderful, thanks Mira, and I'd like to very much welcome every member that has been able to log in this morning for the Collaboration Prize discussion. And I'd also like to welcome and congratulate the shortlisted finalists. Next slide, please. So this is a really exciting opportunity, I think, for the Alliance and our Alliance members. We have a history of addressing the surgical needs of children around the world, men and women, and who have little or no access to life-changing surgery. But the exciting thing about our alliance is that this is a place where big thinkers can come together, where different organisations from around the world are working side by side with a common goal and a common target. And so I'm really, really stoked that the Henry Family Advised Fund have committed $40,000 for this first G4 Collaboration Prize. And some of that focus, the prize is designed to foster new member collaborations and innovative programs to address the needs of neglected surgical patients.
I'd love to speak a little bit on the inspiration for the prize. I've been incredibly impressed with all of the energy that has come together with the G4 Alliance. We have now a collaborative organization that like none has ever existed before in the space of surgery. I'm very, very proud of that. I feel that one of the things that I've seen in this organization is a lot of organizations coming together, meeting their members and leadership, meeting each other for the first time ever. And sometimes there might have been very kind of emotional distance, like feeling that there were rivals in some sense, but then finally getting to meet each other and realizing that we all have the same values, we're all shooting for the same goals, and we're all really, really cool people. So there's been a lot of friendships that have been made in this alliance, and I think that that's really, really valuable. And I want to find ways to kind of bring that more to the surface with this organization. We've also accomplished a great deal organizationally, but I want us to start scoring wins for things that we can draw attention to that the G4 Alliance has done that has concrete on-the-ground deliverables as far as lives saved, people helped, and to show value to the rest of the world in the G4 Alliance in novel collaborations that happened, organizations that have never collaborated together before the G4 Alliance came and did collaborate for the first time thanks to this organization. And lastly, all of the proposals that don't come out as winners in this prize will make a wonderful portfolio of things that the G4 can act on as we're fundraising. If we find donors who want to help push help us with our agenda and push things forward, it's going to be wonderful to have a pre-baked set of projects that that, given sufficient funding, could make a significant difference. So hopefully everyone will be a winner in this process. G4 will be a winner because we're going to help demonstrate to the world the value of this organization, and the individual projects will be winners as we move forward and make the pie bigger for everyone. So that's my vision for the prize.
Thank you. So I thought we'd just very quickly give everyone a rundown of the process before we move to the presentations. So we announced the prize at the last Permanent Council meeting in November, with a formal call for proposals in February, with receipt of those in March, and the shortlist committee review in April. We had 13 fantastic applications that were received. And that had partnerships of 26 G4 Alliance members. We now currently have just over 80 members, so this is over a quarter of the members collaborating and competing for this award. And there are also several programs that included some additional non-member organisations to expand and create greater impact for their applications. So the shortlist committee evaluated the proposal on 3 criteria, that of being impact, collaboration, and particularly collaboration with internally with G4 members, and with a time frame in mind so that we can utilise these the prize for further fundraising later in the year. So there was a review of the 13 applications, and it was a very difficult choice to get down to 6 finalists. That they represent, I think, the strength and diversity of the G4 Alliance, organisationally, programmatically, technically. The applications cross all of our sectors and areas of work, and that's really exciting. And most importantly, they demonstrate impact and the role of collaboration that we have. So very briefly, and I hope people have been able to see some of the synopses that are available on the G4 website at the moment. But we have the 6 prizes, and these are presented in order of presentations. I won't run through these verbally. I think it's more important that we start to move to the exciting presentations. Amira.
Wonderful. So first up, we're going to ask Dr. Ahmed Al-Sayed to join us. And Dr. Al-Sayed, thank you so much for joining us by video conference. We will turn it over to you, and if you'd like to advance the slide, you can say next slide or nod with a hand or a gesture. Thank you so much.
Okay, well, thank you very much. I see, first of all, greetings to everybody. I see everybody's about midday over there, whilst I'm in my early evening gown in my bed already. So greetings to everybody. So our program is Electronic Registry of Trauma and Elective Operations with training of trauma care providers. I'm presenting this on behalf of the collaborators. Next, please. So these are the collaborators. I think we have a very good mix of academia, myself from Al-Zaim Al-Azhar University, and then with 2 other academics, or McGill University Global Surgery Center, and Stanford Medicine Global Surgery Center. Then we have 2 NGOs, the Primary Trauma Care Foundation and LifeWorks Foundation. Next, please. So next, please. So our objectives are to develop a mobile internet-based registry. We think this is quite innovative because we're actually hatching on to the telecommunications sector, which is a big growth industry in all of the world, but especially so in developing countries, where I think it's by far the biggest industry that's growing in our part of the world. So we want to use this registry that we developed to collect data on trauma and elective operations in 5 states of Sudan. Sudan has 18 states, so that's pretty much nearly 1/3 of. In fact, we've added a sixth state, which by our own efforts we did as a pilot. So at the end of the day, the registry, we collect data on all trauma that comes through the door in these 5 states, and that will be a total of about 36 different hospitals. And at the same time, all the erective operations that are being done. We use this data. At the same time we do this, we start implementing the WHO safety checklist, and we have a plan for that, which I'll show in a minute. So, and in addition, we train instructors and providers in the primary trauma care in the 5 states. So next, please. Next, please. Thank you. So we have already started a pilot, as you can see to the left of the screen there, the operative database, which I took a picture of yesterday on my, as it is on my mobile. Now this is a very, very fluid template, so you can add whatever questionnaire you want. We now have a fixed questionnaire. You can see the trauma questionnaire, and we have the other questionnaires for the surgical safety checklist. So this already has been piloted, and we've been trying out internally. We hope to be trying it out in the States pretty soon. To the right, there's a map of Sudan, which the dots you see there are the 5 states. So we have places. There's first of all, in the capital, we have 3 big hospitals, the 3 biggest hospitals in the country, which see trauma, and then we have places which are basically more than 500 kilometers, is going up to 1,000 kilometers away in the extreme east of Sudan, and in the extreme west, the capital of Darfur, North Darfur, the capital of Port Sudan on the Red Sea, and then the biggest city in our north, which is Dongola, about 500 kilometers away, and then in the center of Sudan, Al-Ubaid. We are hoping to add Al Gadarif, which is on our borders with Ethiopia, mainly because I've visited there recently. And to tell you the truth, since we applied, we have done a small pilot in Port Sudan where we've trained some of the providers that we have there. Next, please. So, next slide. Thank you. Can I have the next slide? So now the novelty we think for this is we will be using new information technologies. This coming up with novelty number 3 is partnering with the telecommunication industry. At the telecommunications, we have 4 providers in Sudan. All of them are now running after us because they see this for them as a growth industry. Every telecom operator has a lot of talk, has data capabilities, but they want more and more people to go online. And in fact, we're quite hopeful that between the 4 of them, one of them will donate airtime and data for the year of the project. And in fact, one of them is now talking about sustaining this forever, because for them, they have people on their network. These people will be using other business-oriented parts of their networks. Now, for us, the providers, and for the policymakers, you suddenly have real-time data, thinking into the future. If the pilot goes well and we succeed in it, you have real-time data, so you can know immediately what are needed in this part of Sudan, and you can start planning, and you can help any hospital that is in dire need quickly. The 4th aspect, which we think is quite novel, is we have a North-South-South collaboration, and I might add to that collaboration between the NGO sector and academia. So, at the end, we think we have what could become a model for sustainability and development in our part of the world, and we will be attaining the WHO surgical safety checklist together with the training of trauma care providers who are giving the service in the remote parts of our country. So in a nutshell, that's what I have to say, and thank you very much for taking the time to and shortlisting us in this exciting venture. Thank you.
Wonderful. Thank you so much, Dr. El-Sayed. I'd like to turn it over to our question panel, Orion and Brendan, who are going to be posing some questions.
Sure. So this looks like a pretty cool project. I had 2 questions. The first was just what is the current state of the software? You had some screen grabs there of the software as it stands. Is it already developed and just sort of needs to be tested and polished and deployed, or is it still in the design stage and you need to finish it? And that's part of what the prize money is for.
It's tested. No, we do not have that on the budget. What we want the budget for is to put it. We've tested it inside Khartoum in a limited area, but what we want the prize money for is to fund testing it in the remote states.
Good. And the second question is just alignment of this project with the prize goals. One of the prize goals for this is to make a tangible, concrete impact of people helped on the ground. I have a lot of respect for public health and collecting of data and its use overall, but I wanted to, if the end goal of this process is to collect some statistics and to publish an academic paper, that's very valuable, obviously, but it would certainly deprioritize it compared to a project that's going to more directly impact lives. How do you foresee this project making direct human impact in a time frame that is cogent with the prize goals?
Thank you very much for that question. I realized as I was presenting it that it was not very clear how I'd be impacting. Well, the Objective 1 is the collecting the data, but immediately Objective 2 and 3 are providing the life box oximeters to the places, training. So as we're collecting data, at the same time we're looking at mortality and morbidity of operations, for example, and what is happening with trauma. We hope to divide the project into two phases, the first 6 months and the second 6 months. The first 6 months we're collecting the data, but the next 6 months we have trained trainers in each of these states. So we have a team of 16 people in each state who will be training in better trauma care, which is one of the goals of the PTC, and better surgical safety as applied by the WHO surgical safety checklist. Now, for these two, two of our academia partners, Stanford University, were the originators of, well, one of their staff was the originator of the WHO surgical safety checklist. So we're having him over to train trainers in different states to implement that. So in a nutshell, and the same applies for McGill University with the trauma and the Primary Trauma Care Foundation. So first 6 months we have data, and we train staff in the different states. Then the next 6 months, as we're collecting data, have we made an impact? We're hoping, well, we're calculating that we could save up to something. Well, the WHO safety checklist says it decreases mortality by 26%. We think we're going to have an impact of 5,000 deaths that are saved. Now, we have to test that on the ground, but we're quite excited about it, and we think, and secondly, I must say, I hate to put it this way, but suddenly Big Brother is watching you. So you as a surgeon in a remote area, we know your mortality, we know that if you have a weakness somewhere in your training, we're not advertising this because people will not partner with us to give their data if they think we're watching them. But it's something that we have to think of. How do we, in the long term, look at more specifics? For example, we think that infection rates are rampant in 2 areas of Sudan. We think, we're not sure, because me being in the capital, they are referred over to us here. But there's no data that we can see. So yes, we think we will have a very direct impact. We're calculating total of 70,000 trauma patients who get better care, and 5,000 mortalities less in operations, and about 15,000 morbidities less. However, we have to see how it goes.
Wonderful. Well, thank you so much, Dr. Al-Sayed. And just in the interest of time, I'm sure we could speak for hours. I will ask if we can move on to the next presenter. So thank you very much. And Dr. Al-Sayed's presentation will be online. Next up, we have a special presentation from COSECSA, and this is on their Safe Surgical Checklist application. We've only listed the primary applicants here. However, we encourage you to please look online, and you will see all of the G4 applicants as well as the additional collaborators. As Brendan mentioned, there were over a dozen, or probably 26 collaborators coming together across all the applications. So we'll be welcomed now, or joined now, by Dr. Abebe Bekele, and he is going to be presenting via a pre-recorded video link as he is traveling. And we are pleased to be joined by, as we mentioned earlier, Dr. Rosemary Mugwe, or Ms. Rosemary Mugwe, who's the CEO of COSECSA, as well as Dr. Tom Weiser, who will be able to answer any questions.
surgeon.
I would strongly recommend wearing headphones if you have them to prevent feedback.
My name is Dr. Atal Patel. I am a thoracic surgeon from Ethiopia. I got to Star University.
I'm so sorry, guys. It is ringing. Why don't we, can absolutely everyone mute, just so that we can hear Dr. Abebe's presentation?
Chair of the Examination Credentialing Committee of the college. First of all, I would like to thank all of you for allowing us to record this presentation. I will be traveling back from Cameroon to Ethiopia tomorrow, as the webinar is going on. Let me take you through what we are trying to implement in partnership with you. We are trying to implement a project that is designated to reduce one of the important surgical complications, that is surgical site infection. In short, what the partnership is trying to achieve is we want to develop COSEXA's own safe surgery checklist, which will be owned by the college, will be owned by its fellows. We will identify national leaders that can lead the checklist implementation in the respective countries. We will identify 2 hospitals from the COSEXA, in the COSEXA region, where we will collect appropriate data and then make sure all the hospitals under the college start using the COSEXA adapted checklist. We believe this is a very innovative project. The innovation part is in the COSEXA region, no country or no surgical body has tried to adopt the already internationally accepted WHO checklist to fit the purpose of its region. So COSEXA and its partners will try and adapt the safe surgery checklist to fit the region. The college will also own the initiative. Once the college owns the initiative, it will spread through the 12 member countries and more than 120 hospitals under it. We're not only interested in the ticking off the checklist. We are linking the implementation of the safe surgery checklist with the reduction of one of the important morbidities, that is surgical site infection. We also believe the collaboration is very strong. COSEXA, because it's the regional leader in surgical training, it has broad network of hospitals and professionals, more than 120 hospitals are under it. LifeBox, because it has the world's largest experience in the implementation of the safe surgery checklist. And Association of Academic Surgeons in the US, because of their strong experience in program implementation and training in different regions in the world. We believe the project has a huge impact because the checklist will be linked to the reduction of surgical site infection, and surgical site infection is known to cause increased morbidity, mortality, increased hospital stay, and increased cost to surgical patients. We believe it's scalable because once the college owns it, it will spread to its 10 member countries and more than 120 hospitals under it. Again, thank you very much for giving us the opportunity to pre-record this. My colleagues, Dr. Tom Weiser from LifeBox and our CEO of the college, Ms. Rosemary Mugbe, are here with you now to answer any of your questions. Thank you very much.
And thank you very much to Dr. Bekele for a remote presentation. We will move to questions for Rosemary and Dr. Weiser. And Dr. Weiser, we're going to unmute you to see if you're able to participate. There you go. And Rosemary as well, we will unmute you so that you can join. I'll hand it over to the panel.
Sure. Thank you so much for the presentation. That was fantastic. I'm excited at the prospect of the surgical checklist being deployed throughout COSEXA and Saving Lives. I did want to ask to sort of help clarify for me, being the least medical person here, what it is about the WHO's surgical checklist that is inappropriate in its current state for being deployed in COSEXA as it is. What are the material gains over, or what's sort of like a concrete example of something that you might want to change in the checklist to make it more appropriate for the environment, rather than just to take the official checklist as in its current state?
Rosemary, let me answer that. This is Tom Weiser here. So one of the things that's important on the checklist is that it's locally adapted. And when we first created the checklist, one of the key ways that you get provider and frontline buy-in is to take those components of the checklist and either rearrange them or change them or add or subtract to or from them. So, for example, in a lot of the COSEXA countries, surgeons are present at the time of anesthesia induction. So a lot of the safety checks that come before incision can actually be moved into the pre-anesthesia check because there's a surgeon present. That's not the case in, say, the UK or the US or Australia, where the surgeons are not typically present for anesthesia induction. So you can streamline elements of the checklist by rearranging them. In addition, there are probably other items on the checklist, such as ensuring a power source or ensuring a good light supply that might not be particularly relevant in Europe, but is clearly relevant in parts of COSEXA. So there would be two kind of simple examples.
Excellent. Thank you so much.
I have, excuse me, merely a follow-on question to that. I think one of the impressive points of this proposal was the scale that you're attempting throughout the COSEXA program and region. But I'm just wondering if you've considered or thought how you're documenting the process of changing the checklist and any ways or activities to expand those lessons learned to the broader membership, particularly working in other regions around the world.
So Brendan, that's a fabulous question, and one that we actually at Lifebox are working on as well. How do you develop a roadmap for scale, not just in regions that have specific Lifebox partnerships, such as in Sudan or in COSEXA, but also other places that are trying to do it on their own, and how do you know whether you're ready to make a change, and how do you go about doing it? We're actually in the midst of some qualitative work right now, doing stakeholder interviews in some of our pilot sites where we've actually done some checklist implementation work to capture some of the qualities. We think we have a good idea of how to do it, but I suspect that we're going to learn a lot of new lessons in our COSEXA travel, and certainly in the travels in Sudan as well. And so those kind of lessons are ones that we're trying to capture and actually publicize on on the Lifebox site through blog posting, through kind of implementation type channels. But ultimately, we'd really like to do an implementation science kind of process where there is a very specific roadmap that have if an organization or a group of providers or facilities have specific characteristics, we can identify specific mechanisms for the checklist to be better used when your hospital's characteristics or your facility characteristics, where the leadership comes from. Is it coming from the facilities, from the providers, from the ministry? Because those all take different strategies for adaptation and spread.
Thank you.
Wonderful. Thank you very much to the COSEXA team, the Lightbox team, for your presentation. And we'll wrap up and move on to our next presentation. This is the geospatial mapping of pediatric surgery needs, and we have Dr. Marilyn Butler from GPSN joining us, and I'll hand it over to you, Marilyn. Thank you, Dr. Butler.
I think I've unmuted it. Can everybody hear me? Can I be heard?
Yes.
Okay, great. Thank you. Thank you for. I'll have the first slide. Thank you to the G4 Alliance and to the Henry family for allowing me to present this proposal today. I'll take the next slide, please. Children are dying all over the world because they cannot get access to safe surgical care. We know this to be a fact, and it's not a small problem either, because it's hard to believe, but in many countries of the world, children represent half of the population. We desperately need funding, and we need capacity building efforts at every level of the healthcare system. But we're not going to be able to get that support until we get more numbers. And that's why I hope I can count on your support for this really important project to assess the surgical needs of children. The next slide, please. First, I need to tell you a little bit about imperforate anus, because we're going to use that as a proxy for safe surgery in children. That's never been done before. Babies without an anus are born with a complete intestinal obstruction. They cannot have a bowel movement. All these babies die unless they get a colostomy within the first few days of life. But that's not the end of it. Once they get the colostomy, these children ultimately need reconstructive surgery to give them a new anus. All around the world, children are growing up in poverty with colostomies because they can't go to school, they're ostracized by their teachers, and they can't get a job. They basically have stool spilling onto their bellies all day long. What's different from the life-saving colostomy is that the operation to give them a new anus can occur weeks or months after birth, when they can get to the care of skilled surgeons or anesthesiologists. Next slide. So what is our project going to do? Our goal is to figure out how many people in the world can get to a hospital where a newborn colostomy can safely be performed within 48 hours. And then we're going to determine how far a patient must travel to reach a hospital where reconstructive surgery can be performed to get a new anus. We're going to do this by mapping all the hospitals and LMICs around the world. Then we're going to map where all the pediatric surgeons are in these same countries. And finally, we're going to perform geospatial mapping using sophisticated programs that calculate travel times based on road conditions all around the world. Obviously, we can't do this alone, and we have formed strategic alliances with several organizations both within and beyond the G4 Alliance. Our key collaborator is the World Federation of Associations of Pediatric Surgery. But we're also going to leverage the experience of other G4 Alliance members who have performed geospatial mapping in the past, as well as others who have developed tools for assessing capacity. And finally, colleagues from Stanford University, including Tom Weiser here today, will help us to perform the actual geospatial mapping once we have obtained our data. And we're going to use all the contacts we have around the world to get that data. It's an ambitious project, but with the help of this generous grant, it is definitely feasible. And if we get things right, fewer children are going to die. And what's more, those children who live with surgical problems of all sorts can live their lives with fewer disabilities, and they can go back to being normal children. And the best part is, if the surgical care for children is improved, all surgical patients in the healthcare system will benefit as well. I hope I can count on your support for this important project. Thanks so much.
Fantastic. Thank you so much, Dr. Butler. I'll hand it over to the panel for questions. And just before we do that, I'll encourage anyone who is listening in, if you have questions, please feel free to type them into the panel on the right-hand side of your screen. Thank you.
I just wanted to first thank you for your work. A bit of trivia, I don't know if everyone knows, but when Jamie and I began filming The Right to Heal many years ago, the very first kid we ran into in the very first village we went to was a 3-year-old boy with a colostomy and an imperforate anus. And we followed his family for several years, and 2 years later got him his reconstructive surgery in Manila. So I'm very familiar with this particular problem. Now that said, I just wanted to echo the question I asked earlier, which is that sort of how many degrees of separation is there from the collection of this data and the building of this geospatial map and to children on the ground getting access to the surgeries that they need. With regard to the argument we'll be able to put forward to fundraisers about the immediate direct value of this collaboration.
Thank you. I anticipated this question. I think the biggest thing that's going to happen is that, and through the Global Pediatric Surgery Network, this is already something that's been going on for about a decade or so, but I think what's going to really happen with this project is that we're going to really identify the surgeons and the doctors that need help. And right now, there are dozens of us, maybe hundreds, that have formed alliances with people in various parts of the world, but we're missing a whole lot. And I think what's going to happen with this proposal is that we'll develop new collaborations and new friendships and new collegial relationships with surgeons in many countries that don't have that help already. And I can see parallel to this project having several of us being able to immediately give some of that help that they need in the education and the training that might help the children even as the project is going on.
Thanks, and thanks for the presentation, Dr. Butler. It's a really impressive proposal, and I think it's fair to say they're pretty lofty goals with the outreach and developing this globally. I'm just wondering, you have a large collaboration and you have a large set of networks within this to implement this or activate this. But how do you see activating or utilising the G4 Alliance membership to really drive this forward and support the broader membership within this program?
Thank you for that question. The World Federation of Associations of Pediatric Surgery is probably our primary collaborator. They have more than 100 pediatric surgical societies, and we've been working with David Sigalet, who's president of that organization. We're going to identify all the pediatric surgeons in those societies, and the problem being that some of the members of that society have either retired or they live in countries where general surgeons perform some of the pediatric surgery without being labeled or without labeling themselves as pediatric surgeons. So we're going to have to work closely to identify who the actual people are that are doing the surgery in each country. There has been, in answer to the rest of your question, Tom Mira at the Harvard Global Surgery Center, Dan Panaro at the McGill Center for Global Surgery, and Roy Nahabjit at the Lancet Commission on Global Surgery have all offered to give us assistance with the logistics of tackling this kind of a huge project. In addition to that, the Global Initiative for Children's Surgery, which is a new organization, not a member of G4 at this time, has developed an optimal resource document that will help us identify, to assess the resources at each hospital. So we're basically leveraging the experience of these people in the G4 Alliance who have already performed these kind of analyses so that we're not reinventing the wheel. And with that in mind, Tom Weiser has done some extraordinary work in geospatial mapping, and we're going to use his expertise and his programs to help perform the mapping itself. There have been pilot projects that have been, one of my collaborators in Australia was involved with the Lancet Commission on Global Surgery in Australasia and the South Pacific, and so we're going to use that as a pilot project to begin our studies, and that's what I'm hoping we'll be able to present the results of that region by the November meeting, and then complete the study over the course of the next year or so.
Fantastic. Thanks so much, Dr. Butler. With our board's permission, I'll proceed to the next application, and thanks to everyone for keeping things brief. Next up, we have Dr. David Hoffman, who's joining us over the phone, and he will be speaking on behalf of Healing the Children as the primary applicant on the use of fingerprint identification to provide a unique patient ID with cloud interface. The floor is over to you, Dr. Hoffman. Thank you.
Good morning. Again, my name is David Hoffman. I'm representing a group of organizations, but my initial group is Healing the Children. A little background on what we're trying to do is that for the last 25, 30 years, I've been doing a lot of volunteer work as a surgeon, mostly in South America, and the number one problem that I have and the group I run is Healing the Children in Neiva, Colombia, which I'll talk about in a minute. We do predominantly orthopedic surgery and cleft lip and cleft palate and facial reconstructive surgery. And the problem that's plagued us from year to year, even as we've grown with the use of computers and all that technology, is that we don't have a sustainable medical chart, and we're stymied by basically seeing the same patients every year as a new patient. The names get very confusing, as you can imagine, and it's very difficult to create a sustainable chart. Next slide. So the proposal that I'm suggesting is that we combine three things. Number one, some unique identifier, namely a fingerprint ID. Next slide. Okay, so we do three things. We combine a unique identifier, namely a fingerprint ID, but that can be coupled with other things at the moment. That's what we feel strongly about because they're a very inexpensive item to incorporate. Number two, to create a medical record that the fingerprint ID would open that's relatively simple to use. And number three, this information be stored in a cloud-based environment so that it wasn't dependent on a local hard drive or a computer hard drive. The problems that I see this would solve in our own group, but I think it has broad applications, is that any child in a low-income or middle-income country that, or any, not only child, any adult, anybody who's experiencing surgery where will avoid ultimately the problem that they show up in a clinic situation where nobody has any idea of what had happened in the past, and this is a major problem in my own work. We just can't tell what surgery's been done, what anesthetic problems this patient has had. We're clueless. Every time we see a patient, they're like a new patient, even though they're this. We could have a patient coming to our clinics year after year. So on a worldwide basis, this would be a unique event if we could have some software coupled with an identifier that could be a data bank. Now, go to the next slide. As I was saying, the project that we're suggesting is, and we've linked up with a company called Identizone, which has patents in software and is not only is willing, has been doing the work. We are well along on the project to create the electronic medical record, the chart, and to have it hooked into a unique identifier. And we want to use our first pilot project in our trip in May 25th in Neiva, Colombia, where we'll do two things. We've incorporated the Smile Train chart as our chart, and we've incorporated work done at Boston Children's Hospital, which is our pediatric team, and we'll enter each one of our patients into this situation, then look at the results at the end of that week and see how successful we are to have we created a chart. Does the unique identifier work, and what are the pitfalls in that program? That's the first stage. Down the road, go to the next slide. We anticipate looking at the results of this first project, figuring out where our shortcomings were, and then retool the project, start to use it with the next groups, which are our collaborators, either with Healing the Children or with the International Association on future trips till we certainly can debug it. The ultimate goal, I think, which is really what I'm excited about, is to take the concept and bring it back to the G4 Alliance and say, okay, we've got this basic program that will allow just that unique identifier, electronic record, and it's stored in the cloud, and that we now want to get their input as to, all the questions that are going to precipitate from this. How can it be used on a global basis? Who would watch? Who would store the information? What can be done with, in terms of outcome assessments? We anticipate that all this stuff will be linked. The chart will have a linkage to ICD-10 codes, but we definitely see that this will tell you will help you give us a data bank to look at all the different issues that G4 might want to look into. So this is a basic charting system that we think G4 Alliance could adapt and recommend to all its membership and make this available. There are a lot of questions to be answered as we move along, and I don't think this is the time to answer them. We've been working, and we are pretty much ready to go in our first pilot project. One of the exciting things we anticipate to expand on is the use of smartphones, where that will help us do a lot of outcome assessment, because so many people around the world have a smartphone, and that coupled with our fingerprint ID will enable us to at least start to contact patients that have had surgery, and we'll just open up another whole expansion into this system. Hopefully, I guess the ultimate goal is that this concept becomes the actual property of the G4 system, and that they can use, this can be their software, which they can engineer to use on a whole global basis. Let me stop there and see if anybody has any questions.
Wonderful. Thank you very much, Dr. Hoffman. Over to Orion.
Thank you, Dr. Hoffman. Lots of questions. And thank you for the presentation. This is a very interesting project. First is sort of a technical feasibility question, which is just that have you looked into what the false positive error rate is on fingerprint biometrics? And the reason I ask is because biometrics are really good to exclude a person. So I can have the fingerprints at the crime scene are clearly not mine versus absolutely positively identify that I was there. Usually, even in like a criminal case, you need to combine the fingerprints with like motive or something in order to hone in on the person, because false positives do exist. But in a case where all I have is a fingerprint to pull one person out of 6 billion on the entire planet and associate them with a medical record, I worry that the error rate would be extremely problematic in this situation. I was wondering if you've looked into that, because the medical consequences of pulling up the wrong chart on a person could be disastrous, obviously.
Yeah, we've discussed that, and Idenazone, the company that provides this, has made that very clear to us. That's not the only identifier, but it will, once there are so many different identifiers. First off, what country you're in, the patient's general name, what city you're in, the age of the patient, or that's obviously going to change, but there are a lot of biographical data. The trouble is that when you have all the biographical data without a unique identifier, you can get confused. And once you can say, okay, this patient, for example, is in Colombia, well, that excludes 95% of the database. Then you say, well, it's a male. They live here. This is about, so there are other parameters that will allow you to go into it. We anticipate that a lot of places have medical record numbers. Each country has their own way of assigning a number to a patient. But all those being said, you still get confused. So the fingerprint is not necessarily the go-to one first. It's the one that allows you to say, this isn't everybody else. This is this person.
Okay. Okay, great.
So the fingerprint readers are only about $50 or $60. They're not expensive.
Right. Okay, so the second question is that just the idea of doing these searches off of mobile phones is really nice, and having the cloud database is really nice. When you're recording information, being on a mobile phone in an area with spotty coverage is not a big deal, because the data can sync later when you return to an area with good coverage. But in the case of doing a cloud database search, you're not going to be able to hold the entire fingerprint database cached on a single phone. It'll be too large. What's the story with a tool like this in an area with unreliable phone coverage, or will it only apply in areas that do have reliable phone coverage?
No, the use of the phone is a secondary thing. In other words, your basic storage is going to be in a local computer, a computer on hand. which is easy enough to have. Whether you're hooked into the internet or not at that time won't make any difference. You're just retrieving and storing data. Ultimately, when I suggest the phone, it's that it's too tempting not to use the smartphone as a way to incorporate the fingerprint ID and say, okay, this is a way for us to locate a patient and find that patient down the road. If you, for example, if say we in the NAVA situation, we've done a surgery on someone's hip, and we're interested in how that patient is doing 4 months, 6 months down the road. It gives us the ability to contact that patient on their phone. Then they can plug into our system with their fingerprint ID on the phone, and it may be as simple as say, give us a picture of you walking, show us a video of you walking. Those things all are up for grabs, but at least it will allow us to have a way to communicate with all these patients. If we want to have some recall, if we want to find out how people are doing, if we want to tell them, okay, we're coming next year, or there's going to be a clinic open for you, or it just gives us a way to create a way of communication with patients that we don't have now, other than by just TV mailing. I mean, it just doesn't work.
Right. Excellent. Last question is something you started to get into, but I guess I just wanted to give you a minute to underscore it a little bit more and kind of give us a more concrete idea of what you're thinking about. A system like this would be a little bit useful if it was used within inside of a single organization or a couple of organizations, but individual patients are going to be touching could potentially be touching a lot of different organizations over the course of their life. Surgery they had when they're 12 years old might be from a completely different NGO than the surgery they have when they're 35 years old. But being able to connect those two records is really valuable. So obviously this kind of tool goes from useful to extraordinarily useful if it has brought the most broad adoption possible, where everyone starts using it and the cloud database is shared by everybody. You were talking about using G4 as a platform to try to get broader adoption for this. What are your thoughts on that with regard to, what are your hopes? What are the goals? What do you want to do with the intellectual property? What do you hope to do with the intellectual property? And what about the ongoing costs of I mean, the worry of mine is that someone's going to have to pay for that cloud database. And if it's storing the medical records of an entire planet, it could get quite gnarly. You must have thought through this process. What is your hope to make this so as broadly adopted as possible?
Good question. I think about it a lot. The question I understand it is, we're looking at this thing, suppose it really works, and suppose we want to project out 4 or 5 years down the road. Well, the first thing, backstep a bit, for example, we collaborated with SmileTrain, which has a very successful operation, but has the same problems we do, and SmileTrain's data will be stored. So in the simplest form, we'll give this program back to SmileTrain. All right, we'll just give it back, and at that level, they can decide, do they want to store their own data, or do they want to move on to something bigger or better or more exchangeable? So that's the first step. How to do it on a grandiose scale is a very good question. It cannot be done at this level. There are a lot. When you ask the question, but it opens up 10 more questions. Is it something that we can hand to G4 and G4 can get a grant and then look at it? Is it something that can take it to the World Health Organization? Is it something that we just limit it and say different groups and places can use this software for their own needs, and this is how to store it? I don't really, the bottom line is I don't have an answer if this became huge. I don't have that answer yet. My thinking is very simply, let me develop the program so that I could come back, for example, at the next G4 meeting, show you that we ran this program on 2 or 3 trips, and let you then say, okay, we like what we've seen. Let's get a committee or let's get a group to take it to the next level, whether it be using your input, using many people's input, using it for grant money. But until I can sit down and show you a workable plan, until I can say to you, okay, we did this in 3 different events, and this is how it worked. these were the problems. This is the solution to our first round. This is the solution to our second round. Here's the feasibility, and give you and then I'm going to give you the same list of these are the 20 questions we now have, and throw it up for debate at a G4 meeting.
Well, thank you so much, and I'm very sorry to cut the interesting discussion off for the sake of time.
Thank you.
Thanks, Dr. Hoffman. We are getting so many wonderful questions coming through, and one of the recommendations is that we will present these to the applicants. They'll have an opportunity to answer briefly, and we can post those online for our members just to give justice to all the great questions coming through. If you can, please indicate the organization or the presenter you'd like the question to go to. We'll do our best to match them up. With that being said, we'll move on to Primary Surgery is the Answer with Dr. Michael Cotton from the International Collaboration for Essential Surgery. Dr. Cotton, are you with us?
Hang on.
Dr. Cotton, we can hear you.
Can you hear me now?
We can hear you loud and clear. Thanks, Dr. Cotton.
Okay. Thank you very much for this opportunity to speak about primary surgery. Primary surgery is a widely acknowledged text. It, in fact, been, for the last 30 years, the Bible of surgery in the district hospital in low-income countries. The two-volume work was originally published in 1980 by Maurice King, who's not actually a surgeon, and volume 1 covers non-trauma, and recently we've completed the new edition of this volume. After 15 years of work, it's now published by Global Help, and it's available for free online. It's been downloaded worldwide since publication in May last year, 861,083 times. So we're approaching the million mark fairly soon. It is, in fact, a must-have in the operating room in most district hospitals, because it tells you what to do, it tells you what not to do, and more importantly, perhaps than all those things, it tells you what to do when things go wrong. So innovative is this text that it's still in demand. In fact, the original edition is still in print 35 years on. It is, of course, the condensation of 40 years of surgical experience of surgeons working in the field. And like myself, I spent 20 years of my life in Africa. And it's now used, I'm happy to say, by COSAXA trainees. So its impact is undoubtedly huge. Volume 2, which is trauma, needs likewise to be re-edited and updated. And the chapter outline has already been done and will be presented in Berlin to the German Tropical Surgeons Group, who own the copyright of the volume, in October. And the edition will be written and presented in the similar style. Let's have the next slide. Now, you'll know, of course, that trauma is the scourge of the 21st century, and most surgery that needs to be done in the places where it's not being done is either OB/GYN, obstetrics and gynecology, or is trauma. And the morbidity of trauma and the emergency surgery dealing with it is fairly high. And so this book will go an enormous long way to reduce that mobility. The questions are, how, for example, do you deal in a small district hospital with cases like these? And the next slide. Or this. What do you simply do? Or next slide. Or this. Head injury in the rich world usually means CT scans and the like. Well, of course, that's just simply not a possibility. So you need to know what to do and which indication there is. Next slide.
Okay, right.
Primary surgery is the answer. We've heard of the neglected patient, but we don't hear very much about the neglected surgeon. And this book is not only the answer to the need of the person, of the patient, but it's the answer to the need of the surgeon. It is, in fact, his savior. This is the average sort of district hospital where most of this sort of work needs to be done. And you can see it's not sophisticated. What is the person in the corner looking for? What he should be looking for is primary surgery. This project will be supported by the International Federation of Surgical Colleges and the Association of Great Britain and Ireland, which has made significant support to COSAXA and is basically running their surgical teaching program. So I put it to you, this is what's needed, and I'm very happy if the G4 will be able to support this project.
Thanks so much, Dr. Cotton. Brendan and Orion, off to you. That was a great presentation, Dr. Cotton.
Okay, well, I might jump in with a question then. I really like this proposal. When low-tech solutions come in as an innovation, I think that's fantastic. My question though is using this or developing this as more of a high-tech tool. You've mentioned the number of downloads that are available, and we know that access to internet and mobile phone technology is increasing dramatically as well. I'm just wondering what your plans or ideas are of expanding this into creating either an app or an interactive-based tool that surgeons may be able to utilize.
Well, that's a very interesting question. I think there's obviously a huge amount that can be done online. Various groups do have interactive systems where doctors in remote places can ask for help and so on. But I don't think this is particularly the theme or the project here involved. That's a whole different world, and I think it's very important. I think it's very useful, but I don't see it as the principal aim, particularly of this project. The objection that has been raised for an online edition is that in many places the internet is poor, reception is difficult and intermittent. However, in even the most remote places, for example, a mission hospital that I know in Tanzania, which is really in the middle of nowhere, down the road you can get something printed at a sort of online shop, and they basically wait till their connection is good, and then they print another 200 or so pages, and then when it goes off they stop and have a cup of tea and carry on later. So it is possible to get a print version if you try enough. There are various publication problems with the print version. It's all a bit of a long story, but the fact that the downloaded edition has been printed, has been downloaded so many times, is indicative of the fact that this book is now the most widely read surgical text in the whole world.
Thank you, Dr. Cotton. The sort of assessing what the impact of a revised version of the book would be is a pretty straightforward mental exercise, as well as what we could talk about this to funders towards the end of the year. But one area that isn't as obvious to me that maybe you could help me clarify is the argument we can make if to fund a project like this that the G4 helped bring together the organizations in collaboration for the first time. Tell me a little bit about the organizations that you would be collaborating with to finish this book, and what role the G4 played in these collaborators coming together to work on a project like this.
Thank you. The International Fellowship of Surgical Colleges is a worldwide group that is mainly involved in evaluating college training programs for the various colleges in various countries and assessing their viability, assessing how well they're going, giving each other support. And in this respect, having them on board keeps the how shall I put it, the authoritative academic value of the book high. I think the objection to low technology surgery is that it's not as good as high technology. But of course, that's a bit of a false argument. But nonetheless, it's important to produce scientifically valuable and validated facts and advice. And in that respect, I think that's very important with the IFSC. The Association of Surgeons of Great Britain and Ireland have been the primary movers behind COSEXA in funding and servicing that organization. And it's the society in Africa that basically coordinates the training of surgery. And the impact then of the book through that college is massive. We need the surgeons there to evaluate the use of the book and see if it actually does improve surgical outcomes. And that's also where they come in. I don't know if that totally answers your question.
Thank you.
Very helpful. Thank you so much, Dr. Cotton. It certainly is known as the Bible in the world of global surgery, so thank you. Moving along to our last but not least presentation, we have Dr. Mark Perlmutter, who's joining us from the International College of Surgeons, and he will be presenting on something proposed as the G4 Empowerment Database. And I will let Dr. Perlmutter give us more background on that. Off to you. Thank you.
Thank you. May I have the first slide, please? By way of introduction, I would like to illustrate that our collective goal for the collaborators is to both effectively stimulate and efficiently facilitate the organizational cooperation in global healthcare. This is a formidable task that can only be accomplished by introducing the best accepted best practices that are routinely used in large-scale business operations. Every successful medical system in the entire world is at first a successful business, and all successful global businesses have effective global logistics to both plan and implement programs such as We will start by creating a single global digital registry of every potential volunteer from high-income countries, and then cross-reference this registry with an existing one already developed for local healthcare workers in low and middle income countries. Next slide, please. For the sake of time, let me summarize the slide by asking you to focus on the very bottom right-hand corner of it, and the rest of the slide you could study at your convenience. The salient point is that our digital registry is bidirectional. Not only does it create a system for every volunteer physician, advanced practice nurse, and technician from high-income countries to register their training and their interest and their availability to volunteer, but also host nations will now be empowered to solicit from this registry of volunteers the talent they need to sustain programs that they prioritize. The next slide, please. Developing and implementing such an enormous registry would normally take several years of labor and cost many millions of dollars. So, how does one innovate on a budget of $40,000 while satisfying a unique yet critical challenge to make it scalable so that it can grow and yield limitless returns on the investment? The answer is to not waste resources and try to reinvent the light bulb, but rather redirect its light towards needed concepts. The light bulb we discovered is a software program called Iris Qualify. And the energy powering this light bulb is a G4 member organization, our principal partner, IntraHealth International. This company has served diligently greater than 20 low and middle income countries for greater than a decade in creating registries of all local healthcare workers within the host nation. Our goal is to innovatively modify this mature program within budget to surpass our goals. This slide demonstrates, back one slide please, the early impact of this program after its implementation will be rapidly appreciated as the IRIS database is already serving greater than 1.5 billion people in low and middle income countries worldwide. And the final slide, please. The long-term impact of the program, however, will be realized by its infinite scalability. For purposes of illustration, I have separated just 3 components of international healthcare in this diagram. I propose to you that our software program will seamlessly interface both the needs and resources of all 3. That includes the volunteers, including their supplied materials and equipment, local providers, and host programs. Let's start by looking at the bottom right limb of this triangle, and I will give examples of facilitated collaboration. Let's say that a Conseca and the Kenya Society of Anesthesiologists want to develop a cleft palate program in Nairobi. Our database will allow both member organizations to know the training and the availability of all local providers required. Now let's move to the counterclockwise to the bottom left of the triangle as you look at the diagram. Our software will now enable both of these 2 member organizations or non-member organizations to directly recruit volunteers from high-income countries to help develop this program. Specifically, they can recruit ongoing support 52 weeks per year to meaningfully sustain this training program. For example, advanced practice nurses can be recruited from Cure and Vanderbilt, and volunteer anesthesiologists from Christiana, the Imperial College of London, or Hopkins. They can all be invited by the host nation. A constant rotation of volunteer surgeons is now possible from research, Rhodoplast, the Smile Train, and Plasticoats, and all groups will now be able to, for the first time, communicate and coordinate with each other. The patient triage can now occur digitally well in advance of travel, and this will empower AmeriCares to more efficiently provide needed supplies. Furthermore, for emergency situations, such as disaster relief, a ready pool of qualified volunteers of known availability can be rapidly summoned. Lastly, on the top of the limb of the triangle, and one that I find to be the most critical, illustrates how our system can easily scale to develop the foundation of global telemedicine. Our database creates an international digital consultation service, which is overwhelmingly the most cost-effective way to sustain every healthcare project regionally identified as important. On behalf of all my collaborators and the International College of Surgeons, I thank the Henry family of the G4 Alliance for investing time into studying this project. Thank you.
Wonderful. Thank you very much, Dr. Perlmutter, and kudos to your organization for reaching out to so many of our members to collaborate. That was great to see. I will hand it over to Brendan and Ryan for questions. Thank you.
Great, thanks. First question is, like a platform like this, the utility is obvious if we can get a critical mass of people on it and organizations on it using it. Like, that's very easy to imagine, but as with anything along these lines, getting the first person to get on there when there's nobody else on there to connect with is always the tricky bit. You know, look, Exhibit A being Google Plus, that no one's on and everyone's on Facebook. usually in order to get a really successful launch into something like this, you need to have someone with a decent amount of leverage, leveraging people into there. Like if the Ministry of Health were to say, if you want to do a medical mission in our country, we need to see you on this registry. Or if an insurance provider is like, listen, if you want your program wants to be insured, I want to see things recruited through the system, or something like that, to get the ball rolling. What is the, assuming the software is all written and the database is good and everything's tested, what's the plan to get from 0 to 1 on the first sets of organizations, first sets of volunteers using the platform, so it'll actually get some mileage?
Yeah, that's a great question. Unlike your analogy for Google Plus to Facebook, though, they're already developing and competing with somebody who had their boots on the ground and had a mature system already. Our system has no competition. So
well, you have competition insofar as that people are volunteering for work in missions without needing to register with anyone. They're just the competition is making some phone calls, doing things ad hoc.
Absolutely. And which is why when we first started this project, we reached out to almost every G4 Alliance member, and as you can see by my initial application, even several that are not G4 members. And we have buy-in from everybody. And so moving forward, they've all agreed to use their volunteer registries to use this program and shift over to it. Now it is true that some, like Cure, had said, well, we don't have the personnel to pay to retrospectively have people enter themselves into this database. But it's something that the volunteer can enter themselves. It does not require a full-time equivalent employee of any of the member organizations to go retrospectively back into their database. It simply requires an email saying, please re-enter your data for our volunteer database into this new format.
My second question is, I know a lot of energy has been spent over the years trying to assess surgical capacity of existing providers on the grounds. Is there a version of this that would start to catalog and accumulate data on what surgical capacity exists natively within these regions, not just the volunteer missions coming from out of the country?
Let me see if I understand your question right. When you say surgical capacity, do you mean denizen providers?
District hospitals, district ORs, things like that. I mean, assuming that a lot of these missions are going to be taking advantage of or connecting with local hospitals to use their operating room or to connect with their doctors. Some won't, obviously, but having databases of existing district hospitals and surgical capacity, which this stuff will be touching, is very valuable to a lot of people in this space. And I was wondering if there's any plans.
It's absolutely critical. I have myself gone to remote parts of Ecuador and found that another surgical team was there unbeknownst to us, and then the capacity, the physical plant, was not able to absorb everything, and hundreds of hours of work for both teams was wasted. And there was no coordination on the ground, and that's part of the premise of this project, and that's the waste of human resources and material resources and equipment is huge and largely responsible for the greatest loss of investment into surgery into low and middle income countries. The beautiful part of this program is that the host country and the needs that they define drive it. So the owners of the capacity are the ones that really control the program. It puts control of overseas mission work in the hands of the host nations. So I used to go down and say, okay, I'm a hand surgeon, and I would go down and say, I'm going to fix 15 polydactylies a day for 2 weeks in Loja, Ecuador. Well, that has a valuable role for sure, but this program allows the host nation and the host country or a host training program to say, now let's identify local people that we can train to do this. And this is the capacity that we have, and therefore we're soliciting these volunteers for us to do this project. It really becomes bi-directional. So the part that you address is really historically the mainstay of volunteerism. I want to go overseas, I want to find a place that needs me, and then I'm going to make it happen. If a program is better coordinated with the host nation, and the focus becomes on training are actually empowering the facility to become a center of surgical excellence. That's the only way that we're going to train local surgeons of excellence, and anesthesiologists and obstetricians, obviously, and lay providers. So the coordination has to be bidirectional for education to be maximized. So in short, we're not eliminating the host program from the owner of the capacity from the formula. We're empowering them.
Excellent.
Thank you so much to all of our presenters. With that, I will hand it over to Brendan for closing remarks. And as mentioned, we will take your questions, unfortunately, not now, but we will take them online and try to post those answers for everyone's reference. Thank you.
Thank you, Mira. And again, I'd like to thank all the wonderful presentations today, as well as the other organisations that spent a lot of time in preparing your proposals. Unfortunately, we can't grant to all 13 participants or organisations, but it was, again, very exciting to see that amount of interest coming in for the G4 Alliance Prize.
I certainly say after this presentation, I'm very motivated to see that we do get all these projects funded, because it would be a shame if any of them don't.
That's such a good point. The proposals are all fantastic. I'd just like to quickly also thank the team behind the prize, the G4 Alliance staff, Mira, Alberlina, Shannon, and Sarah. But most importantly, I'd really like to again thank Orion and Jamie Henry for their incredibly generous support, not just for this prize, but to the G4 Alliance overall. It's just a wonderful support for our network, and to be able to see the potential that can be applied through their support is fantastic. Just a couple of closing notes. Voting will be open for 1 week, and the Google Docs form for voting has been distributed. Each organisation gets 1 vote for the prize, and that will be ranking the six proposals that you've heard today, 1 to 6, and have 1 vote for each organisation closing in 1 week. We'll be collating those votes and announcing the winner at the Permanent Council meeting in May on the 20th and 21st of May. Also, just for those that are still here, I'd like to note as well, we have a WHA Advocacy Coordination call next Thursday, May 11th at 11 a.m. Eastern Time. So if people want to join that for a WHA update and next steps for our advocacy program, and also a reminder as well that our next Permanent Council call is Monday, May 14th at 2:30 Eastern Time. So on those final points, I would really like to thank everyone's participation and everyone for logging in to the prize, and I'm super excited to find out the next steps and the outcome of this. So on behalf of the G4 Alliance, I'd like to thank everyone.